overview of crossover-related processes. These processes are designed to support providers in ensuring member continuity of care through the transition to the standard plan. Trish Farnham is with us today from the division and will be our lead presenter today. Please note there are some Alliance staff members on the call today. A few housekeeping notes. We will take Q&A through the chat box today, so please remember to only communicate through that chat box. The questions that we cannot answer will be captured in a Q&A document and posted to our website. With that, I will turn it over to Trish. Trish, please let me know when you need us to advance the slide, and Todd will be able to assist you. Thank you, and welcome, Trish.
Thank you, Christy. Hi, everyone. And Christy, just to double check, can you hear me?
Yes, double checking. I can hear you well. You're
awesome.
Ready.
Awesome. All right. Always the first thing. So good morning, everyone. I hope everybody's having a decent week so far and recognize how incredibly busy all Medicaid providers are at this point, but certainly our behavioral health colleagues in particular. So knowing you have a lot going on, obviously, with your own organizations and your own practices, and you are working in the Medicaid context, and we are getting ready to undergo our biggest transformation in our 40+ year history. Not to forget that we're still all working in a pandemic. So just wanted to acknowledge that this group is a very hardworking group and that you all have carved out time to be here today. And I hope that the materials we share with you are helpful and support your efforts to prepare for, again, the biggest transformation we've experienced in our Medicaid history. So with that, I'm going to go to the next slide. We know that there is so much going on right now, even just within the Medicaid space, that we want to make sure that we're very clear on what we're talking about today. And knowing that providers have to think about all aspects of this transformation, not just our particular agenda items. I'm hoping that the resources that I provide later in the deck can be helpful in getting you where you need to go if, for whatever reason, the question that is on your mind is outside the scope of today's presentation. I also wanted to acknowledge that we are going to be focusing, as Christy said, on the concept of transition of care. And that transition of care concept, as we'll talk about here in a minute, is really about that migration of members from this current health service delivery system that they are currently in to one of the 5 prepaid standard plan health plans that will go live on July 1st. We know that, again, there are other dimensions at play here, and that will soon become a dynamic. So we know that the tailored plan option is obviously something you all are paying very close attention to. I did want to manage the expectation that because that tailored plan option doesn't launch for another year, and July 1st of 2021 is right around the corner, we are focusing this presentation on that transition to the standard plan option on July 1st, and I will not be fielding questions about the tailored plan design or the tailored plan direction. Next slide. So I know this is a very, very well-informed group, and I want to also acknowledge that this is a repeat performance. So if you have, we are doing a pretty rigorous presentation schedule with all of our LME MCO partners. And so this presentation that I'm going to be doing today should be nearly identical to the presentations that we have been doing earlier this spring and that we will do in subsequent presentations under other LME MCOs as well. So I just wanted to acknowledge that you may have heard this presentation before, and if you need to reprioritize your time, I certainly respect and understand that. But we are going to go through, again, the presentation that has been presented a number of times at this point this spring. And we're going to start with our kind of foundational slides related to the Medicaid transformation endeavor in general. Recognize very well-informed population and very well-informed provider population. certainly understand these slides may be a rehash of things you already know, but just to make sure that any of our new colleagues are kind of firmly footed in the overarching transformation design before we dive into our transition to care aspects. We're going to go through those on the next few slides. Next slide. So the transformation initiative has been consistently driven by the vision that's established on this slide, and that's to improve the health of North Carolinians through innovative, whole person-centered and well-coordinated system of care that addresses both the medical and the non-medical drivers of health. And hopefully all of us who have been in the service delivery system for a while can appreciate the goals that underpin this particular vision. And we hope that as we get into the transition of care design work specifically, that you'll see this vision operationalized in really meaningful ways. Next slide. So just some of the basics about what is happening on July 1st. We are moving to what we can frame as a Medicaid managed care system, service delivery system. We typically refer to that managed care system as the standard plan option to distinguish it from things like the tailored plan option. But we are moving toward a much more comprehensive Medicaid managed care model on July 1st. What does that actually mean? It means on July 1st, most 1.6 million of our Medicaid beneficiaries will transition to one of the 5 prepaid health plans that are reflected on this slide. Importantly, you'll notice that there is still a sizable minority of Medicaid populations that will not transition on July 1st. So we want to, at the very top of this presentation, outline some of those key groups that will not transition. And this is not an exhaustive list, but it are certainly some of the key priority groups. So for example, if a member is both Medicare and Medicaid eligible, if they are dually eligible, the duals, those members will not transition on July 1st to a standard plan. They will continue receiving services as they do today. If a child is currently enrolled in the foster care program, those children will not enroll in a standard plan option on July 1st, and they will continue receiving services exactly as they do today. If a person meets the criteria for being enrolled in the tailored plan, we typically call this a tailored plan eligible population, meaning that they have significant support needs that warrant services that will only be available in the tailored plan or meet other clinical criteria. Those people, those beneficiaries will not transition on July 1st. So it's really important to understand that while the majority of the Medicaid population will transition on July 1st, there is a substantial subset of the Medicaid population that will continue to receive services exactly as they do today. From your all's perspective, and we'll talk about this in a bit more in a minute, it's going to be important to understand your members' eligibility, and it's going to be important to understand which services the health plans are going to be providing and which services they will not be providing. Just to note, because we have a lot going on in North Carolina right now, and on July 1st, we will also be launching in partnership with our Eastern Band of Cherokee Indians Tribe, the tribal option, which will be a primary care management model for eligible members, and that will also launch on July 1st. That is a much smaller initiative, and it may not impact anyone you serve, but we did want to make sure folks were aware that it was also launching on July 1st. Importantly, that will not be discussed during today's presentation. Next slide. Oh, thank you. So I've already mentioned some of these terms in our presentation already, but we want to make sure you have some grounding in some of the terminology that I use today and that is being circulated as part of our transformation activities. And we know that there is so much information swirling around that the terminology can be a bit confusing, or perhaps is new. And so we want to make sure to make sure folks have a clear sense of what we're talking about. You may have heard the term North Carolina Medicaid Direct, and that is a newly branded concept for basically describing our current fee-for-service delivery model, or our current service design as it exists today. And so when you talk about people being in Medicaid Direct, we're talking about the people who will remain receiving services as they do today after July 1st. I've already mentioned several times the concept of North Carolina Medicaid Managed Care. And just to reiterate, when we say managed care, Medicaid managed care, and certainly when I reference it in this deck, we're talking about the services and the model that will be implemented by those 5 prepaid health plans, often called PHPs, often called health plans, sometimes called the standard plan option. All of those terms are related to the same dynamic and the same model of those 5 prepaid health plans that will begin providing comprehensive supports to 1.6 million beneficiaries on July 1st. Another note within this particular term is when we talk about July 1st, we also reference that as the managed care launch date. You may see acronyms like MCL. You may see acronyms like effective date. So all of those terms in this presentation and in related documents really refers to that July 1st date, and we want to make sure people are aware of that. Finally, like I mentioned earlier, the tailored plan service delivery design is well underway in its development. This will be, as the name suggests, a plan tailored to provide comprehensive supports and approaches to serving folks who qualify because of their behavioral health support needs, because of their developmental disabilities, because of their traumatic brain injury supports. These folks will qualify for a plan, a comprehensive plan tailored to meet their particular needs. This plan, like I said, is outside the scope of today's presentation and will launch next year. Next slide. So just as we all within the transformation effort are driven by the vision that I mentioned earlier, the transition of care activities also have its own North Star. And that's as beneficiaries move between service delivery systems, the beneficiary will maintain continuity of care and the burden of the transition will be minimized on providers. So we are working under this vision in order to, as we develop the architecture and implement the architecture under the transition of care workflow. Next slide. So a couple of important kind of qualifying points about how we are defining transition of care and exactly all the different dimensions of this concept. So you probably are very familiar with the concept of transitions. We know that in the human service delivery space, people experience transitions all the time. And so transitions has a very large connotation, or can be have a very broad connotation. In this particular context, we align the concept of transition of care with the federal regulatory requirements. And we're talking about the experience that a person has as he or she transitions between health plans or service delivery systems. So it's not necessarily about a physical transition from an acute facility back to a home-based setting. It's not necessarily a transition between pediatric services or services that people age out of. It's not necessarily specific to that, although we have tried very hard to really honor the principles of any transition planning in this transition of care design. In this transition of care design, we are talking about the protections and the safeguards that have been established to support beneficiaries who will transition to one of the 5 prepaid health plans on July 1st. As you can appreciate, after we all experience the massive transition on July 1st, individuals will continue to change plans. They will have the proactive opportunity to do so, and they may change from one health plan to another. In North Carolina, we have a specific, some very specific legislatively mandated transition dynamics that also have to be considered. So if a person who is otherwise eligible for the standard plan and enrolls in one of those 5 prepaid health plans, later becomes part of an exempt or a carved out population, meaning that they become dually eligible. Unfortunately, the child enrolls in foster care. Perhaps the person will warrant services that are only available through the LME MCO. We have to think through the transition dynamics of how those members will be supported to return back to the Medicaid Direct program. And so when we talk about transition of care, we're also thinking about those particular disenrollment dynamics that I just outlined. Next slide. So I've already alluded to this concept, but I do want to make sure we have one final terminology clarification. So when we talk about transition of care, we do recognize that there are 2 dynamics that literally happen almost immediately back to back with each other, but have different, there's a different architecture, and the volume of transitions is much different. So we want to acknowledge that when 1.6 million people transition to one of these 5 prepaid health plans on July 1st, that concept and the architecture that is established to support those members is known as the crossover dynamic. So when we talk about crossover, we're talking about the July 1st experience that many of our beneficiaries will have. When we talk about ongoing transition of care, we're talking about the much more ad hoc dynamics that exist as members choose to transition between health plans, frankly, starting July 1st, but certainly on and after July 1st. We're also talking about the dynamics where those folks who hit one of the legislatively carved out or exempted populations then transition back to Medicaid Direct. So we have comparable architecture established to support members in those ongoing transitions of care experiences, but that's not going to be the topic of today's conversation. Next slide. So I know you all have probably seen versions of this timeline over the last several years. We just wanted to provide an updated version. This slide is about to meet its next really important milestone. For the last 2 months, we have been in an open enrollment period where members have been receiving letters indicating whether they do need to select a standard plan health plan or whether they have the option to select a standard plan health plan. And then the open enrollment period, which again launched in March, continues to be available for the next couple of days, but will close this weekend. Those members who are required to transition to a standard plan option but have not otherwise proactively chosen a health plan will be what's called auto-enrolled. Based on a variety of demographic and clinical factors, they will be auto-enrolled into one of those 5 prepaid health plans. As you can appreciate, our next major milestone will occur on July 1st. That actually should probably be a red star because that is the significant date that we are all tracking toward right now. And then to round out the slide, there will be a 90-day choice period for members to transition health plans as they deem fit. I want to note that transition of care is an incredibly interdisciplinary dynamic. We are not eligibility experts. We are not benefits experts. However, we have to work incredibly closely with all of our different work streams to make sure that we create a transition of care structure that acknowledges the dynamics that we work within and also addresses the population-specific dynamics that we may have. I raise this on this slide because we know that there are likely questions you have about open enrollment, perhaps some of the letters people have received. And I'm going to provide some resources for where you can your questions, but I will not be able to provide any specific information about these enrollment dynamics or these eligibility dynamics today, or I may not be able to provide the specificity you need. So I just wanted to make sure that that was clear. Next slide. So again, all of our transition of care activities occur on top of the underlying eligibility and benefit policies that our state has established through legislation and through our department. And we want to make sure that as we talk about transition of care, we certainly want to reiterate some very fundamental benefit and policy design decisions and policy design that will impact how people transition and the providers who support them. So this slide, and you've probably seen a version of it before, this slide has been well circulated in various forms, and this slide represents, and it's an important slide, this slide represents the behavioral health facing services that will be provided on July 1st by both the standard plan and the LME MCO. And on the right side of the slide, you see the services that remain covered only by the LME MCO. So it's very important for our provider community to appreciate which services are available under which service delivery model. And if you provide services on the left side of the slide, you may be very well serving people who are in the standard plan. You may also be serving people who remain with the LME MCO. If you provide services on the right side of the slide, you will likely be supporting people who are remaining in the LME MCO. Although it's important to note that standard plans are under the EPSDT requirements, the federal EPSDT requirements, and many of the services that can be only provided in the LME MCO have to be provided to those children within the standard plan. So there are some exceptions to that general rule, but generally it's important to understand where these services will be managed after July 1st. This is also a really important point to reinforce the point that I hope is clear at this time, in that the LME MCOs will remain very operational on July 1st. That's been a question we've asked, and we need to make sure everybody is very clear on that. The LME MCOs remain operational on and after July 1st. And for members who are receiving services and will continue to receive services through the LME MCOs, things won't change. They'll continue to receive services exactly as they do now. Next slide. So we're about to pivot to getting into some of the specific transition of care design aspects that we have worked over the last several years to develop and implement that are focused on those members who will transition on July 1st. Next slide. Recognizing that this is continuously a work in progress and that we are always sequencing and phasing in our protections that are established, we wanted to provide a summary of those dynamics that we're talking about today and put it in kind of in a larger timeline so that you can have an appreciation of when these different activities will go into effect. Next slide. So we recognize that the best way to make sure that there is not service disruption on July 1st is to fully ensure that people are in the appropriate service delivery model before July 1st. And there have been significant efforts underway among our eligibility, our tech teams, to ensure that people who meet the clinical criteria or the service criteria to remain with the LME MCO, so they meet what's typically referred to now as tailored plan eligibility criteria, that those folks have been fully identified in the various claims and encounter detail that is used to identify these folks, and that those folks do not receive letters to require them to transition to the standard plan. However, and this is to the credit of our LME MCO partners, however, there is an understanding that there will be people who are currently authorized for services that are, or utilizing services that are only available in the LME MCO. And those members may not yet have claims and encounter detail to reflect their need for that particular service. So over the last several weeks, and we'll continue this for the next few weeks, the state and the LME MCO network have developed a protocol to identify those members who are currently receiving or authorized to receive services, but have not yet, or within the LME MCO, but have not yet been identified in the claims extract as being tailored plan eligible. So every week, we actually work with our LME MCOs to receive the data and ensure that those members who are identified as receiving services who are only available in the LME MCO have their eligibility modified so that they can continue to receive services as they do today. We do have some specific LME MCO specific protocols for services that do not require an authorization. And I'm going to turn it over to Kathy and our Alliance team to walk through the sidebar here on the slide.
Sure. Good morning, everybody. We will be, folks will be hearing in the next week around, will be contacted around returning some information to us that will help in the rapid identification process for folks that are currently receiving SAIOP and SACOT services, to provide us who within those services are receiving services, because as you know, we're not going to be able to pull that data via authorizations because those services have the pass-through periods. So we will be sending out spreadsheets that will be asking folks to send us each week through June 21st that will identify any of the members that you're serving with SAIOP and SACOT. And we'll also be reaching out to providers that we've identified as having an SUD diagnosis that also require a warm handoff in order to obtain the release of information that will allow us to share the information with the standard plans as part of the transition period. For folks that, if we are unable to get that information, then you'll be required to go through the standard plans to get the authorization. So just for the SAIOP providers or SACOP providers, please be on the lookout, as well as there'll be some SUD providers that are serving members that will fall under the warm handoff criteria that we'll be reaching out. So, and it's real important to submit these very timely so that they can be processed, and because we're very committed to getting everybody where they need to be for July 1. Thank you.
And we'll talk a little bit more about the 42 CFR Part 2 consent work here in a bit. So next slide. So as we start getting into the weeds of our transition of care design, specifically those design elements that are focusing on crossover, we are working under a number of design priorities that are reflected here on this slide. And so over the rest of throughout the rest of the presentation, I'll be providing some updates and an overview and some updates on some of the design work that is again in place under these design priorities. So our first priority is absolutely to do what we can to facilitate uninterrupted service coverage for these transitioning beneficiaries. And so in just a minute, we're going to talk about some of the prior authorization, or as you all typically refer to it as service authorization protections that have been established to support the beneficiaries and their providers through this transition. The next thing I'm going to highlight, or one of the other things I'll highlight, is the importance of the data transfer that will activate, or that has already activated, that has activated and will continue to activate through July 1st and in perpetuity, to really make sure that members who transition, that their health plans have the data that are needed to help support that member to inform the care management, risk stratification criteria, and to ensure that services remain, that continue without disruption. As you can also appreciate, we hope that our design has reiterated the priority of clear and organized communication between entities. As you all can fully appreciate, if you've ever done a transition, you know that communication is critical. And so our LME MCO partners, our health plan partners, our CCNC partners, and our state teams have worked very closely to develop communication channels and pathways so that there is not any ambiguity about how to connect with each other and how to communicate dynamics or issues as they come up. I'm also going to be talking about some of the safeguards that we have established for some of the higher need members who will be transitioning. Like I mentioned at the beginning of the presentation, a lot of our more vulnerable populations are carved out of the managed care model. And so, like I've mentioned several times at this point, children who are in foster care, people who are duly eligible for Medicare and Medicaid, and folks who are identified as being tailored plan eligible are carved out or exempt from the managed care transition on July 1st. However, even within that 1.6 million, we still have a sizable subset of people who do still rely on Medicaid for more than just the occasional doctor visit, and really do rely on Medicaid for often a day-to-day service support. So we want to make sure that we have thought through the supports needed for those members to make sure that their services don't experience service disruption after July 1st. And finally, we know that one of the best assurances we have to making sure people are okay on July 1st is to have an empowered member and provider network and population. And so the last part of our presentation today will be providing some resources for you all to make sure you all are clear on where to get additional information, and to give you some information that may be helpful to your clients as they navigate this transition. Next slide. All right. Like I said, the first thing we are going to do, job one, is always to facilitate uninterrupted service coverage for our transitioning beneficiaries. And so the next few slides, we're going to talk about some of the authorization architecture that we've established to help facilitate this goal. Next slide. So, as everybody who works in the Medicaid space can appreciate, service authorizations are essentially one of the backbone vehicles for a person to access services. And we want to make sure that the architecture and the data transfer supports are established to make sure that people can continue to receive services after July 1st for services that they are authorized to receive. So what does that actually mean in a process, from a process perspective? Importantly, for all members, the LME MCOs will continue to process service authorization requests for all members enrolled up to 11/59 prior to MCL. So up to June 30th, you will continue to submit all authorization requests that you would always submit to the LME MCO. You will continue to submit them to the LME MCO regardless of the member's upcoming managed care status. Business as usual up until June 30th, up and through June 30th, excuse me. Our tech teams and our LME MCO tech teams and our health plan tech teams have been working very, very hard to establish the design architecture, the data transfer architecture needed to ensure that those prior authorizations that are authorized by the LME MCO and recently closed prior authorizations transfer to the member's health plan. So all authorizations that are submitted and received and approved and are considered open or recently closed will be transferred from the LME MCO to the member's health plan. Those prior authorizations, and I use the term prior authorization, but it does apply to service authorizations as well. Those prior authorizations are required to be honored by the member's new health plan for at least 90 days after launch, unless the authorization expires sooner. I do want to note, and we'll talk about this a couple of times throughout the presentation, the underlying statement that PHPs are required to honor open prior authorizations for services that they cover. So we want to make sure that it's very clear that for services on the left side of that slide that we talked about a few slides ago, the services that the PHP is also now responsible for, they will honor those authorizations for 90 days unless the authorization expires sooner. If the health plan terminates that authorization or limits that authorization, reduces that authorization, after 90 days, it must issue appeal rights. I want to also acknowledge the double asterisks here at the bottom. So as you all can, this is a preview to slides that we'll talk about in a little bit, but as you all can appreciate in this particular provider population space, 42 CFR Part 2, the federal requirement related to information sharing for members who experience a substance use disorder, is very much at play with all of our data transfer and all of our information sharing protocols. So we'll talk about how we are working with the 42 CFR Part 2 requirements in order to ensure that impacted providers can still benefit from these protections that we've outlined here. Next slide. As I mentioned earlier in the presentation, transition of care works incredibly closely with our benefits, our clinical subject matter experts, our eligibility experts, in order to create a comprehensive set of supports for people who are transitioning. And we recognize, because of our clinical subject matter expert insight within our state team, that there are service delivery dynamics within our behavioral health space that would not otherwise be impacted by the prior authorization safeguards. And so we want to make sure that in order towards the goal of member continuity of care, that services that do not yet require an authorization will have also the same level of protection. And so it's important to know that, as the slide indicates, unmanaged visits, services that have unmanaged visit counts will reset to 0 at launch. So if a member is transitioning on July 1st and is currently experiencing one of the services that are reflected on this slide, their unmanaged visit count will reset to 0. Next slide. So this is a really busy slide, and it hopefully can serve as a bit of a desk reference, but we did want to make sure you had a scenario-based slide to understand the different dynamics that may be at play with authorization requests around July 1st. So the way to orient yourself to this slide is to start with the gold line down the middle. And the gold line down the middle reflects essentially July 1st. It's the managed care launch date, managed care effective date that we've talked about. On the left side of the slide are the times before July 1st, June, now, where a member is covered by the LME MCO. And then, hopefully logically, on the right side of the slide under green is the time when the member is now covered by the health plan after July 1st. So the first scenario that we're going to walk through is the one that basically I've just walked through earlier slides. And that's when you have an LME MCO generated prior authorization for a service that's also covered by the health plan. And in this scenario, prior to launch, the provider submits the auth request to the LME MCO, and the LME MCO authorizes the service as clinically indicated. That authorization is transferred as part of the daily prior authorization data transfer file to the member's new health plan. After July 1st, the new health plan is required to honor that authorization for minimally the first 90 days unless it expires sooner. If the authorization extends beyond 90 days and the health plan terminates, it must issue appeal rights. Scenario 2 is a reflection of why we are working so hard to identify members who really need to stay with the LME MCOs because of the services they're currently authorized to receive. But it's important to understand how this dynamic will actually play out. In scenario 2, a provider submits an authorization request prior to the managed care effective date for a member transitioning to the health plan for a service only covered by the LME MCO. The LME MCO is going to process the authorization, but it's important to know that after July 1st, that service may no longer be available to the member's health or for the member. And so we all recognize that it is incredibly important that these members are able to remain with the LME MCO so as to mitigate and minimize the risk of this particular scenario ever occurring. In scenario 3, we have a retroactive dynamic in that a provider submits a prior authorization retroactively. So the provider submits the authorization for dates of service that have occurred before July 1st, but submits that authorization request after July 1st. Very important to know that if those dates of service are covering times that the LME MCO has provided services, that LME MCO can process the auth request, but can only authorize dates up to the managed care effective date. If additional units are required for July 1st or after in this retroactive dynamic, the provider will need to submit a new authorization request directly to the member's health plan. Next slide. You all, we're probably going to rework this slide in subsequent slide decks because the information shared is, some of it's really obvious and some of it will soon be updated. But we did want to make sure that you had some key notations about supports and things to consider as you are preparing your practice or your organization for Medicaid managed care launch. We want to make sure that the first step will always be to make sure that to know if this member is actually transitioning. Again, like I continue to say, a sizable number of folks will not transition on July 1st, and that's particularly irrelevant in this particular provider network. So the first thing to be mindful of is whether the member will transition. We have worked in tandem with our eligibility team and NC Tracks to establish provider portal functionality that will enable a provider to find a member's Medicaid managed care status and, as applicable, their plan through the Medicaid provider portal on the recipient information. We're currently working to establish the screenshots that can be helpful to tutor providers in how to see this data and to understand where they're looking for it. As those are available, we will certainly circulate it among our LME MCO partners as well. That functionality is technically live now, so you can go around and play with it, but the functionality only enables people to see 30 days in advance of the current eligibility. And so the functionality would not necessarily reflect the details of that member's managed care status after July 1st until later in June, or until in June. The next thing to know, and this is pretty common sense at this point, and given that we are no longer doing a staggered launch like we did in 2019, it's important to have July 1st circled on your calendar. It is going to be, there is no indication that our launch activities or our timetables are going to be modified in any way. We are on the runway and we are about to take flight. So it's really important to know that July 1st is going to be a key time frame, and your operational procedures and your workforce dynamics may need to be considered in order to accommodate this change. Also, like I've said a couple times on the earlier slides, people need to be very mindful of what they're submitting a prior authorization for and when they're submitting it. So if you have a PA request, and that PA request needs to be submitted before July 1st, it's going to be submitted to the LME MCO or whatever vendor you need or you use currently. Up to June 30th at 11:59 p.m., those prior authorization requests will go to the vendor that you currently submit them to. If you have a prior authorization request that is submitted for dates of service that has an effective date, an anticipated effective date after July 1st, you will need to submit that authorization request directly to your member's new health plan. And we're going to provide some additional resources that may supplement what you've already received on how to best do that. And the last bullet reflects what I just said, in that there will be additional resources that we will provide through this slide deck about how to access the information for supporting a prior authorization to a particular plan. Next slide. So recognizing, like I said at the top of the presentation, that this provider community, as all Medicaid provider communities are extremely busy. And you all are already, your day job is not to monitor Medicaid managed care. Your day job is to support your clients. And we recognize that. And so in addition to developing safeguards and protocols that hopefully streamline this experience for you, we've also established what we call technical stoplights to make sure that people don't erroneously submit a prior authorization to the wrong place and subsequently the member experiences a service disruption because of that. So we've outlined all of the safeguards that we've established on the page. Importantly, like I said, intensive provider education is a key piece of this strategy for making sure that providers are clear on what to submit and where. And like I said, we are doing this training a number of times this spring in towards this goal of making sure providers are clear on the process. You will also see as you go to July 1st that if you try to submit a prior authorization request for a member who is now covered in the standard plan, you will now find that in many cases you will not be able to do it. And the functionality has been established to literally block the submission of a prior authorization request for a member who is no longer covered by the LME MCO. You will also have banner messaging on the PA submission portal, on the service authorization submission portals that indicate maybe what the issue is, that the authorization request is not going to be able to be submitted because the member is now enrolled in the standard plan managed care option. And finally, we are working with all of our UN vendors, including our LME MCOs, to make sure that their call centers have the resources that they need to field provider questions that will inevitably come. And so we also are wanting to make sure that our call center partners within our UN vendor partners are prepared to support providers and to point them in the right direction through this process. Next slide. So we're not going to talk a lot about appeals because we anticipate this to be a fairly rare dynamic, but we do want to acknowledge that if a member is undergoing an appeal for a reduced or terminated benefit, the appeals process will continue. Our goal is obviously to ensure member continuity of care. And so it's important to know that health plans will be required to honor continuation of benefits if a member is under a continuation of benefit period upon transition. If there is a denial of an initial request, it will be important to know that the provider will need to resubmit that request to the PHP if the service request is still warranted. Next slide. So this is probably a pretty common sense slide, and we are not here to talk about provider reimbursement, but we do understand that through crossover, we want folks to be very clear on which direction they would go to submit a claim. So claims for dates of service prior to the member's standard plan effective date should continue to be submitted to the LME MCO. So even if that claim is submitted after July 1st, if it's for a date of service that's pre-July 1st, it should be submitted to the LME MCO. Claims of dates of service after the member's standard plan effective date should be submitted to the member's PHP following the applicable PHP protocol. So again, consistent with the prior authorization requirements. If that prior authorization in effect and that provider is under one of those transition prior authorization safeguards, and there is a claim that needs to be submitted, even if it's an authorization that was authorized by the LME MCO, if it's for a date of service for July 2nd, 3rd, 4th, 5th, anytime forward from July 1st forward, those dates of service claims would be submitted to the to the health plan. We also want to acknowledge that we have a time or a crossover specific out-of-network provider protection, in that for the first 60 days, minimally the first 60 days after launch, all out-of-network providers will be treated on par with in-network providers, meaning that they would experience the same either PA requirements or allowances that in-network providers have, and the reimbursement rates would be comparable. Next slide. I'm going to pivot now to a different dimension of our transition of care design and talk a bit about some of the additional safeguards that we have established for those high need members who are transitioning to our standard plans on July 1st. Next slide. So it's important to recognize that all members who are transitioning on July 1st, all 1.6 million beneficiaries, will experience a number of the protections that we've already established. So when we talk about the data transfer, when we talk about the honoring the prior authorizations, all of those protections will continue to be established for all transitioning members. Like I mentioned in an earlier slide, there is still going to be a subset of members who transition on July 1st who require Medicaid or depend on Medicaid for far more than just, like I said, the occasional well child visit. And we want to make sure that those folks are clearly identified and on the PHP's radar screen in order for them to closely track the members' experience after July 1st. And so we refer to this particular population as the high need population. And we'll talk about who's in that population here on the next slide. Also want to introduce the concept of the warm handoff members, which are a subset of those high need members. And those warm handoff folks are people that the LME MCO, our CC&C partners, have flagged for the health plans as having particular social vulnerabilities or are in a particularly dynamic state at the transition and deserve a clinical briefing between our LME MCO partners and the health plans to ensure that the health plans are aware and oriented to dynamics that may impact the member's continuity of care, but may not be fully reflected in the data file transfer detail that's being provided. So we want to make sure that we have, again, a safeguard for those times where there really is a conversation that's warranted. And we call this particular subset the warm handoff population. Next slide. So as I mentioned, our high need population is a subset of the 1.6 million members who will be transitioning on July 1st. And the high need member list is included or reflected here on the page. And it includes members who use LTSS, and in some cases that list has been further qualified for folks who have experienced emergency department visits or hospitalizations who use LTSS. But as a general reflection, it's members who use LTSS, members who have experienced crisis behavioral health services but have yet transitioned on July 1st, members with inborn errors of metabolism, which is a metabolic disorder that requires very, very tight coordination around nutritional supplements. Members who have been, like I said, identified by the CC&C or our LME MCO partners as requiring a warm handoff. Members who are experiencing a care transition from a high-level clinical setting, so people who are in the middle of a discharge at transition. And then we've highlighted the red line here for this particular presentation, and that members who are tailored plan eligible, or often referred to as standard plan exempt, they don't have to transition to a standard plan option, but they have proactively selected to transition to a standard plan option and will be transitioning out of the LME MCOs. those members are flagged as high need members. We also include members who are authorized for transplantation, authorized for out-of-state services, which often serves as a proxy for high clinical need, and other high need member groups that are identified through our transition experience and certainly by the plans directly. We know that the plans have supplemented this list in some cases to identify other members that they really feel like deserve, or not deserve, but warrant, all people deserve it, but warrant a very high touch, high engagement at crossover. And so the plans will be required to make contact with each of these members within 3 weeks of launch. And that is not an attempted contact, that is actual contact with each member to ensure that services have been maintained as intended. Importantly, the department is also using the subset of this population or the subset of the transitioning population to conduct look-back surveying. So we will be sampling the same group of people to determine if the members' services have been maintained as intended and to ensure that if there are issues, the health plan is fully aware of them. Next slide. So importantly, in order to honor our goal of minimizing provider burden through this process, we have established processes that really are implemented at the LME MCO health plan level. However, we recognize that nobody knows their beneficiaries better than the providers who serve them. And so as our LME MCO partners and our PHPs are working to identify members who require a warm handoff, you may experience a question or a query from your LME MCO in helping identify those members that you feel are really particularly vulnerable in that particular time period and merit additional briefing discussion. So we do not expect this to be a reoccurring requirement or certainly a heavy expectation, but we did want to make you aware that this dynamic may happen. The other dynamic is that, as you can appreciate with 42 CFR Part 2, if a member is covered by 42 CFR Part 2, the entities involved are limited in sharing information related to that substance use disorder dynamic without a consent. And so in the cases, if an LME MCO identifies someone requiring a warm handoff or warranting a warm handoff and does not have consent on record to communicate information about that member's substance use disorder, providers may be asked to help secure that consent in order for that warm handoff to occur. Next slide. I'm going to pivot to another complementary dimension of our transition of care design and talk a bit about the data transfer. While this is not going to be probably the most impacted or the most relevant aspect of the transition of care model for you all, we did want to make sure you were aware of what was occurring and the different dynamics related to it. Next slide. So it's important to know that data becomes an enormous piece of all of our transition of care protections. As you can appreciate, claims data and encounter data are essential in helping inform the member support strategies and ensuring that the plans have insight into the member's current service delivery portfolio. As we've talked a lot about in this presentation, prior authorizations and ensuring those prior authorizations are transferred wherever possible in order to ensure that plans are aware of the services people are authorized to receive and then can honor those authorizations along the lines of what we've established in this presentation. And then finally, we want to acknowledge that there are member-specific, member-level detail that is not fully reflected in prior authorization or claims detail. And so we have worked with our CCNC partners and our LME MCO partners to share additional clinical information as is viable. So our CCNC partners will be transferring a care plan for every member who is actively care managed by CCNC at the time of the transition. And our LME MCO partners will be providing what's called a transition summary file or transition summary sheet for those members who are warranting a warm handoff. So again, trying really hard to have multiple layers of data in order to ensure that the members' various dynamics that are at play on July 1st are fully appreciated by the health plan. Next slide. Again, to talk about the provider impact of these data transfer dynamics, in the case of the claims and encounter detail, we expect that to be literally none because that process is largely being operationalized between our health plans and NC tracks. With our prior authorization transfer, the entire architecture is hopefully established to minimize provider burden. However, in this particular provider community, it is important to know that 42 CFR Part 2 is a factor. And we're going to talk about in just a minute some of the workarounds that we've established so that providers impacted by 42 CFR Part 2 can still benefit from the prior authorization timeframe protections that we talked about earlier. And again, like I mentioned just a few slides ago, we, as LME MCOs, identify members for warm handoffs. If that data are impacted by 42 CFR Part 2, you may be getting a request to help secure a consent in order for that information to be shared. Next slide. So I've alluded to this slide coming up several times and just wanted to make sure that we did at least put at a high level a bit of a note about 42 CFR Part 2 specifically. The first thing I want to say before we dive into any of these particulars is to reassure you that we are doing a separate and distinct presentation on 42 CFR Part 2 at Crossover. And I want to make sure you're aware of the two dates that are listed on the bottom right-hand corner of this slide. So those presentations will be repeat of each other, so you don't need to attend both. You're welcome to. But we will be going through the department's intended direction for 42 CFR Part 2 data, particularly related to prior authorization detail. So to back up just a bit, again, I know this well-informed group is probably very, very well aware of the day-to-day impact of 42 CFR Part 2. But for those of you who may not interact with this particular federal requirement, it is essentially a federal regulation that safeguards member information when that member has been using substance use disorder-oriented services or experiences a substance use disorder, and that data are in the clinical record. And so we have to be very mindful of that regulation because information of that type cannot be shared with another entity, even the member's health plan, without affirmative consent. And so we wanted to make sure that we came up with a process that really honored, or at least certainly recognized 42 CFR Part 2, complied with 42 CFR Part 2, but also honored the prior authorization safeguards that we've established for all services. And so the intended direction is that providers impacted by 42 CFR Part 2 will be required to resubmit their authorization, their standing authorization, directly to the member's health plan after launch. However, upon resubmission, that authorization will be honored as if it had been transferred with the PA data file transfer. So upon resubmission, even though it is technically a submission to the PA, to the health plan, as opposed to being part of the data file transfer coming from the LME MCO to the health plan, that authorization will be honored according to the 90-day protections that we talked about earlier in the presentation. And we'll talk much more about this in these upcoming trainings, so we do encourage you to grab one of these links and go ahead and register as soon as you can for one of them. Thank you so much. All right, next slide. So we're now pivoting to our last component of this presentation, and that is the design priority related to member and provider education. And just wanted to acknowledge, and I think there may be a couple of slides. I think we missed a couple of slides. Can you go back, Todd? Okay, something got loopy in the sequence. No problem. Can you go forward? Can you go forward? I just want to make sure we haven't. Yeah, there we go. Okay, you can go back to that other slide. I just want to make sure that we had this content in the deck. So just to acknowledge that because members often rely on their providers, frankly, for all sorts of things, including a lot of information about what's happening in the system, we do want to make sure you have a couple of key flags for how you can support your members. The first thing to know is that if people are asking about what the heck is going on and what if they're required to transition, or I got a letter and I don't know what it means, those kind of questions, we hope you will help direct the member back to the enrollment broker. And we'll provide that information here. You're probably very aware of that entity at this point, but we did want to make sure that all roads can lead back to the enrollment broker on questions related to eligibility and managed care status. So we encourage providers to redirect members to that particular resource. The other dynamic, and this is obviously becoming a bigger and bigger factor, is we want to make sure that providers are contracting with these 5 prepaid health plans, and that those contracting efforts are finalized before July 1st. So we want to recognize that while that's outside the scope of transition of care, we know that that is a huge component for member continuity and in order for a member to remain with the provider that they choose long term. Next slide. So this slide to me serves as hopefully a resource slide for folks in understanding what resources are available to help both members and providers navigate this particular endeavor. And one of the things that I, as an aside, I really appreciate is that over the last several years, and certainly in preparation for this round of Medicaid transformation launch, the department has dedicated significant resources and energy into developing and improving the resources that are available to both members and providers to educate them on what on this dynamic. So the first resource that I just mentioned is the enrollment broker. The enrollment broker really does serve as the member's point of contact for kind of a disinterested guidance through the process and selecting a health plan that best meets that person's needs. And so the enrollment broker really does become the front door for many of the managed care service delivery dynamics that members may have questions about. Also, that has been recently launched is the Medicaid beneficiary portal. And this is I think a very impressive evolution in earlier beneficiary facing materials that were on the department's website. This provides resources for beneficiaries, not just about Medicaid transformation and managed care, but about eligibility, about services, about our fee-for-service program. So it's important to know that it's much broader than Medicaid transformation, but it is a new resource that is available for beneficiaries, and we strongly encourage beneficiaries to be aware of it. The next 3 bullets are more provider-facing, although they are all open to the public. And that the first one that I want to highlight is I wish I had put a star by this one, in that it's the Medicaid, North Carolina Medicaid Help Center. You all may already be aware of this resource, but I refer to this resource as North Carolina Medicaid Google. It is literally a search engine and a platform that you can query to ask questions about any topic that is Medicaid related. And if resources have been published about that topic, or if there have been questions that have been subsequently answered on that topic, those questions and answers and those resources will appear. So a really, really helpful resource that is refreshed daily. It is very much a live working portal and is very, very closely managed to ensure that the materials are available and that the answers that people submit questions to are answered timely. The fourth bullet is on our website, and you may be familiar with it. It's also an incredibly important resource, and that's the Medicaid Transformation Provider Playbook. And we're going to give a couple of slides here that give some additional detail. This is also worth bookmarking in your own browser to make sure that you're aware of the resources that are available. This website reflects or provides some incredibly helpful desk references related to things that you need to do to prepare for managed care launch, things that you need to know immediately after managed care launch, things like how to submit a prior authorization request and organized by health plan. So you have a one-stop desk reference for prior authorization protocols by health plan. And again, strongly encourage you to take a look at it, and we'll talk about it a little bit more a little bit later. The last detail that we always want to emphasize is that certainly as we get closer to launch and as providers contract with our health plans, those health plans become the most important resource for health plan specific guidance on any provider topic related to prior authorization submission, claims reimbursement, service coverage. The plans really are going to be the best resource for their plan specific flexibilities that they may have provided in addition to the ones that we're talking about today. Next slide. This slide is a little bit of outside the scope of our transition of care work, but we did want to make sure people were aware of it because the design work certainly is enabling beneficiaries to have an uninterrupted service experience at launch. And it's related to how NEMT appointments will be able to be scheduled. So as you can appreciate, members' healthcare doesn't stop or doesn't pause just because we are now moving to Medicaid managed care. And we recognize that members have appointments on the books for July 1st, July 2nd, going forward. And so we want to make sure that we have taken a belt and suspenders approach to ensuring that the transportation needed to get to an appointment has also been fully supported. So importantly, our NEMT teams, our DSS, and our member engagement teams are working very closely with the health plans to ensure that they get NEMT data directly to help inform the transportation dynamics and the supports that may be needed for their upcoming members. In addition to that, we have also set the expectation that the plans begin accepting transportation appointments, transportation reservations in June for appointments that will occur in July. So starting in June, the member service lines that the member will have access to through their particular health plan will begin accepting reservations for appointments that occur in July. It's important to know that if a member has an appointment need or transportation appointment need in June, they still need to call the current their current NEMT resource, typically the DSS. But we also want to make sure, like I've said, that beneficiaries have a runway in scheduling their transportation needs to meet appointments that are scheduled after July. Next slide. And we've gone through this one. You can go. You can go to the next slide. We're about to talk about several of the website specific supports that are available to you. And our first one that we're going to highlight is the Transition of Care website. So if you want to bookmark this site, it is our Transition of Care hub. It does include our Transition of Care policy, and additional supporting documents that may be helpful to providers. It also provides a link to the provider portal resources that I mentioned earlier. So it provides a link to the resources about the fact sheets about how to access prior authorization or how to submit a prior authorization. So we're trying very hard wherever possible to crosswalk resources so that regardless of which direction you go or whichever link you decide to use, you can get to information that's available throughout our webpage that may be helpful. Next slide. Again, to advance our goal of a robust provider education, and I've already mentioned this on an earlier slide, as you all are navigating the prior authorization submission experience, you should experience the safeguards of seeing banner messaging on all of our all of our UN vendor portals, indicating that if a prior authorization is unable to be submitted, it may be because of a member's managed care status, and providing instruction on what to do next. Next slide. Again, we just want to point you in the direction of resources that are being also made available to support beneficiaries who are transitioning. And we want to make sure you're aware that there are fact sheets available, again, through the Medicaid managed care resources in the transition to care space, where member-facing education materials are available. So we have two in particular that we want to highlight. This one is, frankly, about to become a little bit moot as we enter auto-enrollment. But we have developed a fact sheet for people who experience disabilities or are older adults to kind of guide them on how managed care will impact them. The recognition is that a lot of our most vulnerable folks will not transition, and yet sometimes that's not clear. Sometimes it's complicated to understand why a neighbor or someone in the support group got a letter, but I didn't, or my child, we didn't get one about my child. So we've created this fact sheet to assist people in understanding the different enrollment dynamics that may exist for their particular population. We also have a fact sheet that reflects supporting how, or that is to help support a member to prepare for managed care and to have a one-stop resource of who to call based on their health plan. So if they experience a disruption in service, if they have an issue with a provider, if they have a difficult time refilling a prescription, those are the kind of dynamics that we are paying very close attention to, and we've created an educational resource for members on these fronts. Next slide. Again, I keep reiterating the provider playbook. I wanted to make sure you had the full link, but if you, as all things in the world, if you Google NC Medicaid provider playbook, it should take you right to it, but we did want to make sure you had the full link as soon as possible if you don't otherwise have it. Next slide. And finally, these are some of the details that are available through the provider playbook. So again, really encourage you to spend some time on that page and become familiar with these resources. Next slide. So we are now pivoting to our final slide before we open it up for discussion and questions. And this is actually related to what will happen on July 1st, or starting July 1st. We recognize that we've been talking about crossover, and that's the experience of people who are going to be transitioning on July 1st. And we've talked about the protections that will be available for that transitioning population who are transitioning from our Medicaid direct service delivery landscape into one of the 5 prepaid health plans. But like I alluded to at the beginning, we know that our ongoing transition of care activities really start July 1st as members choose different health plans, as members meet different legislatively carved out eligibility standards. So for example, we know that even on July 1st, there may be members who are in the standard plan and warrant tailored plan only services, and need support to transition back to the LME MCO. Hopefully, if we've done our job, this will be a fairly exceptional situation and a fairly rare situation, certainly at July 1st. But even as we move forward, as new people become enrolled in the Medicaid program, and as people experience behavioral health crises for the first time, we know we need to make sure there is a clear pathway back to the LME MCO wherever appropriate. And so this provider community is probably aware of the concept of the raise your hand form. and the concept of supporting a member to identify as requiring an LME MCO specific service in order to receive services and to remain with the LME MCO. That process is being modified to be modified for a post-launch state, and to ensure that that process as it exists now is modified in a way that is consistent with the process now, where a provider can support a member to transition to the LME MCO using one of the transition request forms that will be soon available on the website. We just want to make sure you're aware of this, that this process will also go into effect on July 1st in order to support members and providers who require LME MCO facing services and do not currently receive them and require transitioning back to the LME MCO in order to access them. So more information to come, but we did want to make sure you were aware that this dynamic would be available and would exist starting July 1st. At this time, I'm going to turn it back over to Kathy, Todd, and Christy for any final thoughts or any final Alliance-specific comments before we transition to our questions. So, Christy and Todd, I think I'm handing it back to you all and Kathy.
Okay, thank you, Trish, for that presentation. We do have a couple of questions in the chat. Looks like about 3 or 4. So I want to see if you are able to answer a couple of them. If not, we can definitely document that and get answers out. Hello?
Yeah,
Trish?
I'm here. Are you going to read them out? Nope, I'm here.
Well, let's start with number 1. So this is a good question related to authorizations. Are the PHPs required to honor the COVID flexibility, such as the relaxed authorization process?
That's a really good question. So the answer is a little nuanced, and we're actually going to be communicating something more formal. But if the flexibilities have been activated through the state Medicaid program, the answer is yes. They are required to honor it. If the flexibilities have been activated at the LME MCO specific level, we're still confirming that answer.
Okay, great. And the next question looks more so of a scenario. Can you give a scenario in which a client who is eligible for the tailored plan would be better off opting for the standard plan?
That is, I think, a fair question. I think it's also going to be very member specific. And so the scenario really is about supporting beneficiary choice. And there may be a number of reasons that a health plan may be the better option for that particular member. It could be a case of wanting a more holistic coordinated care system. It may be a particular provider dynamic. It may be frustration with the current service delivery system. It could be a case of one child is already going to be enrolled in the standard plan, and so the family wants both children to be in the standard plan. There's a lot of different reasons, and again, it's very member driven. The enrollment broker can help a member be guided through that process. And it's also important to know that there are other safeguards that are also being implemented right now. And our LME MCO partners can certainly appreciate this, where members may not fully appreciate what they may lose if they transition. And so there are activities underway right now to engage those members who have selected a health plan to confirm their understanding if they will lose particular services, that is still their preference to transition. So just wanted to acknowledge that the number of reasons there's a number of reasons that could happen, but we want to safeguard members from making a choice that may detrimentally impact them. And so we're working to ensure they understand the impacts of those decisions.
Definitely. Now, this next question is related to, I guess, the timeliness of receiving information. Okay. In this scenario, it's a child was receiving occupational therapy and the parent has yet to receive a packet from the department. Could it be assumed they are going to remain in the Taylor plan?
I wouldn't, I don't assume anything anymore. It is possible that child is exempt, but that may not be the full case. I think oftentimes the best thing to do is to direct that family back to the enrollment broker for confirmation of their eligibility or their child's eligibility for which service, or excuse me, for which managed care status.
Okay, excellent. Oh, one question is related to, I guess, copays, charges. Under any of these plans under Medicaid, will there be any copays or charges for services passed on to the recipients?
So this is outside the scope of transition of care a bit, but there are safeguards and protections that align the copay requirements or allowances that the plans are under with the current Medicaid fee-for-service copay structure.
Okay. Okay. And then there's a last question. It's kind of like a comment. I'll just actually, since it's in the chat, I will name it. My agency is treating many children that are in foster care. Most have clinically bonded to their clinician. We all know that that is correct. That happens. We are moving to the PHP from the MCOs effective July 1st. If our current foster care population stays with the MCOs, the clinical bond would be broken, resulting in more problems for these children. I guess it's more of it's just a thought in the department right now with the transition.
I think it's important to reemphasize, and this is a provider decision, is that contracting with the PHPs and contracting with the LME MCOs is not an either or dynamic. So providers are strongly encouraged to contract with both to avoid the exact situation that the scenario references. It is not an either or dynamic. In fact, we expect that providers will contract with both as applicable.
I think that is very important to point out. I'm glad that you did, and I hope that individual got the answer that they really needed. It looks like one more was in the chat, and I think that will kind of wrap up our time. So, when discussing the list of clients, we would submit who are in the SACOT or SAOP services. What happens with new clients who arrive after July 1st?
So that's a really good question, and we tag team with our colleagues from Alliance on this answer. So if a person presents as requiring SACOT or SAOP services, and again, this is starting to veer into benefits and eligibility, so I'll keep my answer kind of high level. But if a person presents for requiring SAOP and SACOT services, that person will likely need to transition to the LME MCO in order to receive those services after July 1st. So it's going to be really important for providers to be aware of that last slide that I mentioned about the request to move process and the raise your hand request to move process to understand how that dynamic will occur. We do have SAOP and SACOT as a specific service referenced in that process. So the process is being established to support that transition. In addition to that, health plans should be engaged in supporting that member to disenroll to the LME MCO as appropriate. So services would not yet be available or would not be available to that member in the standard plan context, but obviously it would be available as appropriate, clinically appropriate once that member transitioned back to the LME MCO. I will put the universal EPSDT qualifier out there. Not being an EPSDT expert, I can't provide any additional information on this particular dynamic with EPSDT, but I did want to put that out there.
Thank you. Thank you so much. Well, looks like we're rounding out our time. Trish, thank you so much for coming today and giving us the information that we needed as we move through the standard plan and the tailored plan. I do want to make a note to everyone that Alliance also has a Medicaid transformation inbox, and we are checking those to get the most Q&As that will be available for you to help you through this transition. The email box, I did put it in the chat, but it's Medicaid transformation at alliancehealthplan.org, just in case you may have questions that may come up afterwards. Again, I thank everyone for attending today, and remember that the recording will be on the website shortly. Thank you, everyone, and have a great day. This concludes our presentation.
Bye, everybody.
Bye.